It's 9:30. We'll bring the meeting to order. I'll ask Bill to do a roll call, please.
Okay. Dr. Murphy.
I'm right next to you.
Okay. Dr. Papish. Dr. Larson.
Here.
Okay. Dr. Stumiller.
Here.
Dr. Leno. Dr. Coussard. Dr. McGinley. Dr. Kim. Dr. Chung. Dr. McGurdy.
Here.
Okay. Dr. Midori. Dr. Stupple. Dr. Templeton. Dr. Greenhut. Dr. Raybridge.
Here.
Dr. May. Dr. Rowntree. Dr. Spano. Dr. Rodriguez.
Here.
Dr. Brown. Dr. Papish. Dr. Bruck. Dr. Cohen. Dr. Santos. Dr. Felice.
Here.
Dr. Kakuza. Dr. Larson. We did, right? Is there anybody else here that I didn't call?
We have Dr. Wolf.
Dr. Wolf?
Yes, also with Vassar Brothers. Also Vassar Brothers.
That's, okay, thank you. Yeah. Okay, anybody else? So we got 1, 2, 4, 5, 6, 7.
Okay, so we're one short, so I'll
Yeah.
hold on the minutes for right now.
Yeah.
That's okay. So I'll hold on the minutes. We need one more member to make a quorum. So I'll hold on the minutes for right now. We had both at CMAC and at SEMSCO a lot of discussion about our superclonic pilot program. I don't know, Dave, do you want to give a quick update of?
We sure did.
It was a discussion everywhere, but it was all good. Yeah, it was all good. It was just more so talking about the flow of information. Let's call it that.
Yeah. Everybody was very happy with our study and how we had gone about it and the things that we were doing to ensure that we had some data and that it was going along well. Some of the redundant things that we did to try and get the data. And so they're happy about that. What they weren't happy about was that the data wasn't moving from point A to point B. And so we gave a bunch of statistics. I sent out the notes from the meeting, and the parents sent them out to everybody here, I believe. Everybody should have gotten them. If you haven't gotten them, let us know, and we'll make sure that you get them. From CMAC and SEMSCO. And all this, the data is in there. And pretty much it shows that we can have EMTs putting in IJOs, and it's not a terrible problem. They can actually do it. So that's a good thing out of this. We're looking to get more data. We've got a meeting with the state today. We started putting out to all of the agencies the issues we're having in getting data, which on one hand is from providers putting stuff in the right places, vendors not sending the right codes to the state, and then some of the data just not merging across because of those codes being wrong for us to download it and look at it. So we have a meeting with the state today. We also sent out that information to each agency and the agency's medical director so that they get to see what we have on our side of the data form, right? So if you believe that you sent up 10 iGel usages and we show that you've done 2, where's the problem? And so we've got some really good discussion out of that. It's starting to fix some of the issues with at least this project, which will hopefully then go into some of the other data issues around the state as well. Met standards talk about forming a data committee. And so I believe that's happening from the physician level as well. And so that should be helpful too. But overall, there was a lot of discussion all over the place about it.
Yeah.
And there were some unhappy folks.
What was the total? I forget now. So we had
239 potential insertions.
but we only recorded, or we got reports on one.
Complete data on less than half.
On 102.
I was gonna say I thought it was 115, but I'm even overshooting it there.
Yeah. But
Yeah.
once we look at today's, every Monday the state sends us a report on usage overall since the program started. They send a daily report also, but the one on Mondays is the whole thing. Once we look at that, after having sent out all these emails and people scrambling and getting stuff in, we'll see where those numbers are and send out the information.
And we have our virtual meeting at 1 o'clock today, right?
1 o'clock.
Okay. So, yeah, I mean, it's all good. I mean, the bottom line was everyone was quite amazed at how many agencies have signed up for this.
Oh gosh, yeah.
Because we thought, we were going to little Greenville, when we started this, we thought we were going to have a little Hudson Valley thing, and it just exploded. So, I mean, the bottom line there is I think that BLS agencies and many areas are just, wanting to have and desiring to have upgraded delivery of scope of practice. And it really shows that they can insert them. I mean, it definitely has come to that. And thank you to David and all his work and the team, because they've been doing a lot of scrubbing of this data by hand, since we couldn't get the technological side of it to be complete, but really quite amenable.
Yeah, Arlington's going to submit a voucher for my time. So.
Very good. Very good. Her name is Kathy Okel.
That's right.
Okay, so we have a quorum now, so I just would like to draw everybody's attention back to the minutes. They were sent with our packet. I did not see any additions, corrections, or deletions, and I would love to have a motion to approve the minutes if there's no comments. Thank you, Dr. Rodriguez. Second. Thank you, Dr. Raybridge. All right, minutes approved. Moving along, we have a couple of upgrades this morning, or just BLS adjuncts, I should say. Constellation and Pearl River added a pad site on February 9th, and Tustin Volunteer Ambulance Corps added a 12-lead program on February 20th. That's pretty much it. Dr. Felice, I don't think we've had anything from...
Not the...
We're doing good. We're doing good. It's not a bad thing, I'm saying here. It's not a bad thing. Enforcement regulations. I have just a few this morning, not like the last meeting. This is for Stephanie Lugo out of Bronx, New York. Her certification was revoked in August for a violation of Part 800. Leah Cusino out of Staten Island, New York, had her certification suspended for 1 year and placed on probation for 3 years with a civil penalty of $2,000, also for a violation of Part 800. And lastly, Stanford Fire Company number 1, that's in our area, Stanfordville, New York. They surrendered their certificate for the Department of Health for violations of Article 30. That's interesting. So that's in our area. Did you guys know this one?
Yeah, it's discontinuation of, for a length of time, over 30 days. No service for over 30 days. But it's been quite a while. I think, I don't know the exact date, but I think it was like a year or something that they hadn't gone out on a call.
Really? Interesting. All right. Helicopter committee report. Dr. Stumeler, Dr. Larson.
We had a meeting this morning and everything is going well.
Are you going into politics next?
Things are flying in the right direction.
Flying in the right direction. Flying famously. RTAC, I don't think we...
Well, RTEC is scheduled to meet on
It's coming up, right?
Yeah, on the Friday, the 29th of March. It's going to be at 9:30. It'll be up at the Health Alliance Hospital in Kingston. And significant on their agenda is, well, there's a couple things interesting. Well, Health Alliance Hospital, the former Kingston, is going for a trauma designation, so that's one thing. The other interesting, which I find interesting, is that Northern Westchester is going for a trauma designation. And there's a number of, there are a couple of hospitals that are coming up for recertification. A their designation, which includes you, right, New Hudson, and also Montefiore, St. Louis. I think. So anyway, that another thing, no other hot agenda items that I know of on there. But so again, it's March 29th, 9:30 at Health Alliance Hospital on Tuesday.
So is Health Alliance in Northern Westchester going for level 2, level 3?
They're going for adult, I believe, level 2. Both of them are going for adult level 2.
Okay.
Doctor, Health Alliance is a provisional level 3 adult.
Oh,
currently
three?
as of
Oh.
October,
Yep.
Oh,
this past
okay.
October.
Okay.
So we're,
So you're trying to upgrade to a 2?
no, ma'am.
No,
we're-
just
we're-
stay.
Oh,
They're
just
staying-
stay.
yeah,
Okay.
Intended,
We are-
they're staying
Stay
level
put.
3.
It actually,
Okay.
I heard similar about Northern Westchester.
Yeah,
They're
yeah.
Trying to get to a 3.
Yeah,
Yeah.
okay,
Yeah.
because it was interesting, we had, I don't know, I guess it was this past year, you know, the ACS came for our trauma review, and they're trying to push for more hospitals to get level 3. Most people thought level 3 was, what do you want to do that for? But they really would like to see more level 3s out there, so it's a big push from ACS to try to get people on board. This is becoming a fast meeting. Quality improvement report, Jeffrey.
The biggest thing that we still have going is the transition to NEMSIS 3.5. All agencies are required to be compliant by 1 July of this year, and it is incumbent upon the agencies to tell their vendor that they're ready to transition. Okay, that's about it. Hopefully it'll fix some of the data flow problems we're currently experiencing.
Yeah, you guys are above my head when you talk about all these things. Sorry, I am the most technologically challenged individual in the world. Okay, protocol committee, David.
I don't know if that's my jam anymore. No.
No, but
no.
didn't we
Bob
switch
Seeley-
over? Yeah,
Bob Zeeley is going to be heading that
they
committee.
did a
Yeah.
dual meeting.
We did a dual meeting there. He should be coming probably at the next meeting. We talked about moving forward on some of the airway program, the RSI is what it had been called in the past right now. It might have been
Medically
moved away,
facilitated
and then moved back to
intubation.
it, and that's one up, there's a lot of work on that. And it was kind of a short meeting this last time around, as everyone's sort of getting their feet wet, you know, what's going forward. The protocols at the state were all passed, and so that's the alternative medication formulary, the drug shortages, hospice care protocol, the collaborative ALS protocols, direct C protocol changes, and BLS protocols. Those are all passed, and so those are going to be implemented 1st of July also. We're hoping for some training to come out on some of that stuff, and if not from the state, we should probably do something at this level. They talked about that at the protocol committee too. I think the last time we did this, Pam, we had like a 1.5 hour session that we gave folks med control for, and we just went over the updates from the change log.
Yeah, just the major changes,
Yeah.
and they're supposed to go into effect July 1st, so we have a little bit of time, but if they don't bring anything forward, I know Jeremy did a couple of, did you
There's
hear
a
his?
Tylenol thing, and then
Yeah.
Maya did a thing on the
Yeah,
hospice.
his Tylenol thing is way over the top.
Yeah.
It is an hour and a half on Tylenol.
I clicked on
was
it,
like,
and it was
women
2 minutes
too.
about Tylenol, and it's an hour later, and you're like, what is he talking about?
Yeah, no, I did. I actually did the same thing. I kind of got lost in the middle there. I'm like, oh wait a minute, he's still talking about this Tylenol. But it's really good. I mean, I love how Jeremy does things, but I was like, this is an hour and a half on Tylenol.
Everything you'd ever want to know
About Tylenol, its origins. No, so I think we'll watch for that. But I had seen Jeremy had done that, and we can look at, we could do something similar we did the last time, and we can also, try to incorporate other people. They're probably sick of hearing my squeaky voice.
One of the big improvements this time is the change log,
Yes.
which going forward will happen every year.
Correct.
But it's a 3-page document that summarizes all the changes for protocols. The first thing people ask is, what'd you change? And instead of
Right.
trying to search through there,
Right.
you now have a change log that you can see what's been changed in each protocol.
Right. Wonderful. So if we did a CME/med
Yeah.
control on that.
Yeah,
I
that
think
would
it'd be
work.
great.
And, kudos again to Jeremy. He's been facilitating and we have another one coming up soon. He's been facilitating all of these updates. organizing everything and putting it into a fashion to move forward, so.
Yeah, so
No.
that protocol, collaborative protocol meeting, I think is Friday at 9 or?
Yeah, it's-
something
Yeah,
like
it's
that.
next week, I think.
I think it's next
The
week.
8th?
Yeah, end of the week, yeah.
Oh, okay, so it's the end of this week. So, yeah, it just, I mean, the more we do this, the more we become more organized, because when we started, it was like 6 of us, and, now it's the whole state, so. But let's not go any further into CMAC without saying our own Dr. Raybridge was made the medical standards chair.
Yeah.
Thank you, Mike.
Just don't go up to get coffee, right?
Yes,
That's-
exactly.
Or is it the bathroom? Was
The
coffee or
lesson
the
was
bathroom?
Don't leave the room, you'll get appointed to something.
Yes. I don't know if you want to say a few things, just anything?
Yeah, so, I mean, I think everyone knows Lou Marshall chaired that committee for like 20 years.
Yeah,
so-
as long as I've been there.
Yeah, so, big shoes to fill, and, I think we had some very good discussion this time at Med Standards. And, the plan will be to have a conference call, one in between the CMAC meetings, to kind of go over the changes and stuff. So it'll be after this collaborative protocol meeting, we'll have a meeting mid-March, and, to discuss any business for the agenda, for the next.
Well, it's nice because the time comes upon you so quickly, and then in the very beginning, they had this thing, you had to have it in by this certain
Right.
date, and stuff had to happen, so it's just nice for us to touch base with each other, and then we can say, oh, this just came up, or, giving further details on something we're talking about, so I think it's a really good idea. I appreciate that a lot.
And as David said, Med Standards is very, I think there was tremendous support for the supraglottic program, but it pointed out to all of us how difficult it is to get data and do research in the state for a host of reasons, but mostly data issues. So Med Standards was very interested in putting together a group of the physicians to look at, how we collect data and how we can better do research in the state.
Yeah, I was flooded by the guys from the IT department after that presentation. And I was like, it's okay, we'll all work on this, we'll try to figure out what's going on. But yeah, they were flooding me to say, we're gonna work on this, we're gonna make this work. I go, okay. Also from CMAC, just, as David said, the standards, during that time, we looked at all the collaborative updates, we looked at New York City, had a bunch of updates. We talked about iGel, and the medication administration stuff we were discussing back and forth. There was a bit of a controversy over community paramedicine and vaccine administration and antibiotic administration, so these are all things that are further in discussion. Just for everybody, the sunsetting of the EMT critical care, the date's coming, and so that's something on the horizon, which again, isn't happy to some places who just set it up, it sounds like, but, that's where we go. Under CMAC, there was a lot of discussion about the essential services movement, because finally EMS is being recognized for once, and I think that, it's just a great thing moving forward. There's a whole issue with EPCRs and the vendors and similar issues like you were talking about, so it's quite a deal still going forward that has not been, finalized. iGel report we gave, and then I never quite understood EMSC. The committee met twice, since the last CMAC, and he was like, "We're always ready for children program." I'm like, "What is he talking about?" But he's an interesting soul, that one. But it was good discussion. But really, that was about it. We spent most of the time talking about some of these protocols and some of the problems, and a lot of time talking about community paramedicine and vaccine administration, antibiotic administration. Way too long for my sense of attention. I'll say that.
And there was discussion too in the director's report too about the EMS task force that's in the proposed budget changes and how that'll work. So there's been a lot of questions around that. There are a bunch of presentations if you haven't seen one yet. They're kind of doing their little road show right now around the state. Bloomberg is with kind of the plans for the task force and the proposed budget changes and what that means for EMS. The state EMS medical director job is still moving forward, which will now be a full-time job because of the task force apparently. They still haven't come out yet with any details on.
Yeah, because they rescinded it, or they sent it back because it was a part-time job,
Right.
and they're like, no.
Now they made it
it's-
full-time.
It's gonna be too
Yeah.
much to encompass into a part-time job. Yeah, so that's been bounced around as long as I've been there too. That's a long time discussion. Let me just say that.
We also talked about blood regulations moving forward,
Yeah,
and the Community Paramedicine Advisory Group being organized. The Assembly member Pauling was there.
Yes.
And she talked pretty well about EMS, and she's a big supporter. And she also came out and said the surprise to her was that there's no agreement among people in EMS. She says, you all gotta get your act together with that.
yeah.
She like outright said it, just pretty much like that. And they're like, okay, so noted, fair enough, gotcha, heard.
But it is a point from somebody looking from the outside, like, why aren't we just all working together servicing where we live, right? Why don't the counties, I had this discussion with somebody, why don't the counties have municipality CONs and just, be able to, we just use whoever we need, wherever we need, and, it's just hard. It's definitely lacking that we get full coverage and ability to care for people because of those issues.
One other piece about the data is that if the data's not getting to the state, it's also not getting to your hospitals. And so that's one thing that should hopefully be getting better as we continue to fix some of these issues. And in moving to 3.5, that should hopefully work to fix things as well, so that it gets to the hospitals.
It was actually one of our issues in a litigation we had in the emergency department because they could not provide the EPCR. And when it was finally brought forward, it was like maybe a week later. So that was a huge issue they brought up in this litigation. It was very interesting how they brought that in. Did you see that guy got 5 years?
Yep.
Sorry, I'm going off script.
Yeah.
The guy
Paramedic.
The paramedic?
Administered ketamine.
that gave the ketamine and the patient wasn't monitored.
So there was a ton of discussion about this at NEMSB. This was obviously before we sent this, but numerous cases and several good lectures, and it all stems around appropriate assessment and post-sedation monitoring. And I feel like there's where I was going around the new business, but there may be some work to do in education and best practices and putting together some training around best practices. And there was a good talk out there. This guy Eric Yeager from New Hampshire, who good talk on like 10 best practices around this and extreme agitation. And in all these cases he showed, it was little to no assessment before administering the medication and no monitoring after, no appropriate monitoring until several minutes afterwards, and the person had already done everything else.
And the thing there, I mean, that's a long-standing battle for me with nursing. It's like, okay, hey, you gave that nighter, how's the patient doing now? Oh, well, let me go check.
Right.
It's like, so I think it's everywhere. And even the residents, I'm always saying to the residents, you just gave what and how are they now? So it's a huge thing.
Yeah.
But in that case, they were fighting, because I read the transcripts, they were fighting that the police wouldn't give them access to the patient.
So that was another point you brought up. When does a patient become a patient, right?
Yeah.
Police custody.
So that's what he said.
It's
That's
very
in his
interesting.
defense.
And if you look, PWW did a nice webinar on this afterwards, and then there was a good analysis of the case from Colorado, from a commission that Colorado put together, and talked about access to the patient and when does someone in custody become a patient, and the whole EMS police dynamic. So, in fact, they were suggesting more scenario-based training with both together, with police and EMS together.
Well, and they were the ones insistent upon them medicating him.
Well, right, if you listen to the body cam footage, one of the officers said before EMS even arrived, okay, when EMS gets here, we're going to go ahead and give him ketamine and do a,
Yeah,
They were
yeah.
like,
Through
not
his-
a law enforcement tool.
Yeah, through his pants, we're
Yeah.
gonna give him ketamine. Yeah, and then they, whisked him over to the, away from them. And so I was like, he really can't access this patient right now. I mean, I'm not sure, what he normally does, but.
There was a fundamental discussion about the Elijah McCain case, was that it was paramedics not practicing as paramedics,
Right.
being a patient advocate first. That was part of the issue.
Right, and not treat him as a patient.
Right. And so there was just a
Right.
reminder to all that if you are going to be a paramedic, then you must be a paramedic as you would for any other patient, whether they're in law enforcement is involved or not. But then the dynamic between the two
Yeah.
is an opportunity to do
Yep.
joint training.
Yeah, and they didn't even get to assess the guy. I mean, they're just going on what the police had before they arrived on scene. Yeah, that was a pretty remarkable case. And still is, but he got 5 years.
Yep. He got more time than that cop. Got
That's all
like
right.
a little over a year.
Well, they blamed him, right, for the
Right.
death? That, they said
Yes,
it was
they blamed the
his,
paramedics.
yeah, that it was his,
Well, they expected him to have a duty to monitor
Right.
your patient.
To assess and monitor the patient,
Right,
which didn't happen.
And so that was where the,
It was referred to as the chemical equivalent of a taser.
oh, somebody said that? That's interesting.
It was part of the discussion. It was
Chemical
interesting.
equivalent of a
They didn't
taser.
monitor it, they asked for sedation, instead of the police giving them a taser, they had the paramedics administer ketamine, but for the same reasons and for the same purpose.
and it was, ketamine was thankfully not judged to be a weapon.
Right.
Yes.
That was another good thing that came out.
Yeah. But his dosage was way off, though, too, no?
Right. But there really is no ceiling. So they looked at that too, and they said, yes, the dosage was way higher than it should have been, but that, ketamine really doesn't have a ceiling effect. That itself was not the cause of it.
Yeah. No, but I know they were picking on that, on the
Yes.
poor guy, too.
And Peter Antevi down in Florida has done a nice review of ketamine overdoses, quote unquote, and shown no problems with administering higher than the recommended dose of ketamine in a study. So it's, there's some sort of issue. It's like hereditary sedum. It's like Keppra. You can't give too much Keppra.
The only problem is those patients end up getting intubated for airway protection, like, when they get to the hospital, which they might not have needed otherwise.
Yeah, but I still don't think we should vilify the drug. I think ketamine, when properly used and properly monitored, is safe, including safe in the field and appropriate for EMS.
And that's the issue in all these cases, is the lack of assessment and monitoring.
Yeah.
I mean, I don't know about your hospitals, but like for us, if we use ketamine in the emergency room, it's a conscious sedation procedure for the purposes of putting restraints on.
90% of the time, yes. We do have a protocol for using 1/10 of the sedation dose for behavioral management, which would be a useful adjunct in the field.
I like that behavioral management.
Yeah.
I like that indication.
But it might be worth putting together, an educational piece for the region on.
Well, I think
Best
if I was a paramedic, I'd be watching this thing like a hawk, I was watching this thing just because of where it was going. I was afraid of the ketamine issue that Dr. Stuhmiller's bringing up, is I was thinking they were gonna,
Right.
go after us. And
Nobody went there.
Yeah, nobody can use ketamine anymore. And I was like, oof.
Hey, it might be worth it to do a regional med control and say, here's the case, here's the things we learned from it. Watch this video from the.
Oh yeah, that'd be a good one. You wanna do it, Jeff?
Sure, we can do that.
You know what I mean? Just, we could do a little, and we could podcast it, so
Yeah.
people could all get, credit
Yes.
and, medical control,
Right.
and just, keep everybody up to snuff, because now the decision's been made, he got the verdict,
Great.
so.
You have to ask.
Yes.
I think they put it
I think they're
out
okay
that
with
they're
it because
okay
they've been
with it.
sharing with everyone, but we could
That's
just
right.
send them an email.
Just send them and
Yeah.
saying, hey, we're gonna do this without a candidate.
They are attorneys.
One side note,
Yeah. Good attorney.
one
There-
side note,
There was
yeah.
one of the things that came out that all that folks here should know about is that there was a motion to support Bill S 8486, which is reimbursement for treatment, place, and transport to ultimate destination. So those things are ongoing as well in terms of discussions up there. That Medicare, so just for folks here now, at the state level.
Which payer?
Good clearance.
Is it Medicaid? Who's going to reimburse it? Is that going to be finance and private insurance?
Well, so they're talking about that, yes, and also Medicare and Medicaid. And that the Medicare and Medicaid rates are still way under cost to the point that the negotiated rates with some private insurance companies talk about 125% of Medicare or Medicaid, which tells you how low those things are, right? Even for a negotiated rate. So there's still a lot of discussion and movement on those pieces as well to try and get the rates up. That's all I had additional.
Thank you.
Amy Poland is sort of become a big advocate of ours, of VMS. She's a assembly person out of Westchester. And we kind of got to her through, there's actually a EMS advisory board in Westchester that's an official part of the county. And so we started talking to her a while back. So she's kind of, she's frustrated with us as a community somewhat, that we're not unified, as you said. But she is a strong advocate for us. So anyway, yeah, there's a number of issues up, but I think at least we're starting to get some people who have really taken this on as an issue in terms of in the assembly.
Well, at least it's conversation starting.
Yeah.
And some knowledge. And it sounded like she really was interested in the knowledge too. It wasn't just, just to say something to appease us. It's more so she really was.
Yeah, no,
she's engaged.
Strong, she's definitely engaged.
Yeah. All right, open forum. Anything anybody wants to bring up? David.
David made a comment before, and I just want to kind of expand on it just a little bit. When he made his comment about send a bill off to his employer. I don't know if everybody around the room realizes the amount of influence the Hudson Valley currently wields at the state level. Right? So between Dr. Ray Bridges' appointment, David chairing quality metrics, first assistant chair to the state council is Mr. Violante, and then the second chair is Terry Hamilton. And the amount of hours that these guys put in, and it's all unfunded. Nobody's getting paid. If you are, I've not gotten your check yet. But between the hours that Bill puts in, on the committees that he serves, the committees that I serve on, the Hudson Valley wields a ton of respect. The iGel program is just an example of what happens out there. I think at some point, we have to really start to acknowledge, because we can't do it financially, the amount of time and labor and effort that goes into the work that's put into, collectively, of the Hudson Valley steering where the state's going. And I don't know if everybody realizes that or not, but I wouldn't even want to guess the number of hours that are put into there. It's got to be in the hundreds every month. This meeting, that meeting, research, data, everything else. So people don't realize it. The Hudson Valley wields, and I think it gets shown, every time we go to vital signs, the number of winners that come out of the Hudson Valley region across the state. Year before, it was over half of the awards went to the Hudson Valley. This year, there were 2 awards that went to the Hudson Valley. So I just think it's important that we acknowledge the amount of work that goes in, dedication. Thank you.
You're welcome. I think it's a point that we don't always pay attention to. I think your point is well taken, and I think I think the starting point was us getting into the collaboratives and being more as a conglomerate really to work together and just working with our colleagues around the state. But I think that everybody's been doing amazing work. And it goes a long ways back. I mean, you've been in this a long time, David, and Mr. Violante also, and of course our predecessor, Mr. Beninati. And, these guys in the office, I totally agree. I think that, it's all good. I mean, I think it's our responsibility to try to move things forward, because I think, New York's been behind many, many states in this arena, and it's the best thing we can do is to work together, band together, try to promote each other, and see how much we can move forward to, improve what we're doing in the state and in our region for sure. So, thank you. Anything else?
What was the gist version of the community paramedicine discussion in antibiotics,
So-
like without going
Yeah.
into
So-
It was whether that proposed protocol was actually a community paramedicine program or not. That was the first question.
Yeah.
They weren't clear
And what
about
is
that.
community
Right.
paramedicine? What's their scope of practice? What should
Right.
they be doing? And
How
oh
did they
my.
add stuff, because the way it was approved as a demonstration project was that those that are in existence can continue, but you can't change or add stuff. And
So we're going to have one in Westchester, in the Westchester area, and we're scheduled to have an extensive discussion of this next week. But I mean, this is going to be under direct, physician control.
Right, so then that was discussion was, does it even need a protocol, right? Because it's patient-specific orders
Yeah.
being directed by a physician for
Well,
a specific patient.
that's where we all went
Right.
off on to, right?
Yeah, and then, again, it's, okay, so what's gonna be in the pharmacy? What's the span of how exotic are you gonna get with antibiotics, and what are you gonna use? All that, PO, IV. So anyway, I don't know, I can give, at the next meeting, I can give a little presentation as to what we came up with in Westchester, but it should be an interesting discussion.
Well, I think that, like Dr. Raybridge said, most of the preliminary parts of that conversation were is what's in the scope of practice of a community paramedicine program. And, it started off with vaccines, and that we described that, they should be able to go and help administer vaccines, especially during the COVID crisis and all. We recognized all that, but then it, went off onto this antibiotic administration thing, so.
Even the vaccines, like the state now is not sure that the New York City vaccine protocol that passes that actually can be implemented, because in the absence of the executive order, right, for a community paramedicine program, they don't know that they're allowed to do it. Now, we know paramedics and EMTs are trained in IM administration, right? They can be trained on the vaccine, but it comes down to back to that definition of EMS in Article 30, right? It's an unscheduled emergency care, and do vaccines really fall in that or not? So I think it's still with DLA, they're not even sure yet what the answer is.
Well, and it was, because of the executive order that came down from the governor initially,
Right.
that's how we were able to do it before.
Right.
So they're trying to extrapolate upon this and diverge it into
Right, or
other
do you
things.
create the protocol as this is a protocol that gets turned on and off, right, by a declaration by the commissioner or something?
It was a really long discussion, let me just tell you that.
Yes.
Right? Way beyond what it needed to be.
They're also working on, Doug Sambrook from up north is working on out-of-hospital inter-facility transport standards, so that there's something out there now in
Yeah.
that arena, and that's not regulated, right?
Right, because
No.
it's Article 29,
Right.
so you can't,
That's
they're
right.
not protocols, they're just
Right.
best practices,
That's right.
guidance, yeah.
But there's nothing out there right now, and everyone's sort of doing.
We have that little tiny blurb in
There's
the
one line in Article
collaborative.
30.
Yeah.
Says the department shall something
Right, but,
inter-facility transport,
Right.
period.
right,
Yeah.
in the
Shall-
facility, right, it's
shall-
not governed by Article 30, it's what, 28, I guess, so
Right.
it's, you can't make a protocol.
Correct.
Unless the-
We can't govern a protocol or even produce a
But you can
protocol.
make suggestions as
You
to
can
what
make
the best practices
guidelines.
are,
That's
yeah.
that's what we came down to.
Yeah.
The last thing is you can submit best care guidelines, which I think is good. I mean, I think people should have some, guidance from us. So,
And one other thing for new business.
sure.
Honorable but Broken is showing in Kingston, March 7th at 1 p.m. If folks didn't get that email, we could probably send it back out again. You have to RSVP to somebody from, let's just remember, Alvin Naidu. But that's March 7th. Is there still room up there?
Yes.
Yeah.
Last I checked, we had about 60 signed up. I think the capacity is about 125. It's going to be at City Hall. It's 400 Broadway,
No. Yeah, it's 420 Broadway.
right next to the old Kingston Hospital.
And I've been made aware that a number of our politicians who should be there will be there.
Including our county executive.
Our county executive mayor will be there, so, yeah. It's encouraging to see
What
us
time is it, 1 p.m.?
1 p.m.
Yeah.
Honorable but broken.
And it's just a quick RSVP to Pavon. Just to say, hey, yes, I'll be there.
Okay. Thank you, David. Anything else, anybody? Seeing none, I'll ask for a motion to adjourn. And a second, please. Thank you. Thank you, everybody.